Yeah, hello everyone. Welcome to this session after tea break. Yeah, we have our second keynote speaker today. Again, over to Shirisha.
Yeah. Thanks a lot for joining us again. It is my absolute pleasure to introduce Dr. Geetha Manjunath, who is the founder and CEO and CTO of NIRAMAI Health Analytix and has led the company to develop a breakthrough AI solution for detecting early stage breast cancer in a non invasive, radiation free manner. Geetha holds a PhD from IISc and management education from Kellogg's Chicago. She comes with over 25 years of experience in IT innovation. She has proposed and led multiple AI projects at Xerox Research and Hewlett Packard India. Before starting NIRAMAI, Geetha was a lab director for data analytics and research at Xerox India. Geetha has received many international and national recognition for her innovations and entrepreneurial work, including CSI Gold Medal, BIRAC WinER Award 2018, and it is also on the Forbes list of top 20 self-made women 2020. She was recently awarded the Accenture Vahini Innovator of the Year Award from Economic Times and Women Entrepreneur of the Year 2020 by BioSpectrum India. Geetha is also an inventor of 16 US patents and more pending grants. Just yesterday, NIRAMAI was also announced as the winner of the Global Women Health Tech Award by World Bank and IFC in Consumer Electronics Show in Las Vegas. So with that long list of accomplishments, I'm absolutely thrilled to give the stage to Dr. Manjunath, and she will be talking about learning from using machine learning for cancer screening. Over to you, Dr.
Thank
Manjunath.
you very much, Dr. Srisha and Dr. And all the organizers of CommsNet for inviting me for this event and giving me an opportunity to present what we've learned over the last few years in using machine learning for cancer screening, pun intended. Okay, so I'm sure many of you have heard about NIRAMAI. If you're working in AI and working in healthcare and I'm sure you've heard about it. And I also learned that Professor Chiranjeev mentioned some of our joint work that we've been doing with IISc. So just to sort of get started, right? Let's look at this scene of medical imaging itself. You know, we all know that several such equipments are around. If you enter a hospital, you'll see so many such equipments. Trying to figure out through imaging what the human body is doing inside the body, inside the skin, right? You know, by just different types of imaging. It could be, of course, MRI, it could be ultrasound, it could be X-ray, it could be PET CT, it could be you name it. There's so many such imaging methodologies that have been developed over the last quite a few decades, I would say, and the advancements have come. It's been there every 2 years. There is a newer device that is coming in, something that is improvised, higher resolutions coming in, higher sensitivity, higher precision in measurement, and so on. All these machines are trying to look into the body without touching the body. I mean, it's obvious, but it's not obvious when you actually sort of put them all together. It becomes really clear why we are doing this medical imaging. If you want to figure out if somebody has cancer from a large population, it's really not possible to sort of keep on, poking into the, abnormal areas, likely abnormal areas, to actually pull out the tissue and do a biopsy to say whether there is, cancer cell or not. In order to avoid that, what these imaging devices do is to do a quick non-invasive, usually non-invasive ways of analyzing the whole body or different parts of likely abnormal areas, and then figure out where exactly we need to do an invasive procedure, whether we need to do it at all for this person. So this means that you're trying to figure out what's inside from outside. So just one imaging or one type of imaging doesn't work. And that's why you have so many such machines and things going on. What is also interesting is that there is some kind of a guesswork or some kind of a trained guesswork, that the specialist doctors called radiologists do, and they're super important for enabling understanding of these images, right? Having said that, there is a huge global shortage of expert radiologists. One radiologist is, calculated statistically to be serving 1 lakh people. How is it possible, right? So, because if these radiologists are looking at thousands of images every day, trying to say whether there's cancer or not, whether there's COVID or not, all of these, uh, you know, they're all human beings. It can result in some errors. And also eyes have their own limitation and zooming in have its own limitation. So, there can also be issues in the diagnostic accuracy. And how, given human, we really need to have a lot more scale in, taking the shortest time from the radiologist to actually, impact multiple people. Anyway, so in all this is where, artificial intelligence or machine learning plays a huge role. And it is one of the biggest areas, I would say, where AI can make a difference in healthcare all as a whole, right? Healthcare AI in healthcare can, in my opinion, be divided into 3 main application areas. One is for clinical diagnosis, that is helping in clinical decision that the doctor makes. It's called CDSS, clinical decision support systems. And here, primarily, radiological analysis or analysis of radiology images would be a primary area. And the second one is more in terms of treatment, planning, and so on, enabling multiple information, huge amounts of data that's out there on the web to show to the doctor at one place. This third group of applications are generally about improving the operation efficiency in the hospital. So, this being such an important aspect, it's also interesting that we all know, right? AI does well in visual analysis. Could be video, audio analysis. So it's a nice intersection of the need and the advantages that AI provides. And this, again, is the reason why it's a huge area of need and a lot of research happening in this space. And I would encourage many of you who may be wanting to do things in healthcare to just get started here and then, of course, move on to other areas if you find that more interesting. And we are not talking about one disease. So many types of diseases can be detected by just imaging. Of course, we can only go as far as possible because we're not invading inside. But if you can use this for screening patients who are required to get into the final diagnosis or invasive procedures, that's a huge improvement in cost, improvement in enabling high affordable healthcare, high quality affordable healthcare. Anyway, so what we started doing was, many of you do know that we started with this biggest problem to women healthcare, which is breast cancer. It's the top cancer in all the countries. It is the top killer in 154 countries. In some countries, it's the second top. That's it. But it's actually more than 25% of the cancers are just breast cancer. And the deaths also the highest in the same way. The unfortunate thing is breast cancer is really curable. Women can actually live 30, 40 years after a treatment, but we're losing every alternate lady detected with breast cancer today with 50% survival rate in India alone. So, and as you would guess, early detection is very, very important. And in that, affordability, accessibility, accurate diagnosis, non-invasiveness, all of this is a major issue. In fact, use of AI has been tried in this sort of the most common method that is used for breast cancer detection, which is called mammography. Multiple studies have been done. Of course, studies from Google also, Google team also show that there is a possibility of using AI on mammographic images to reduce the false negatives and false positives with a considerable percentage. But there are limitations, right? And in fact, not that, I was just pulling up from PubMed, 198 results just in this area, a lot of research happening. But still there is a gap because the body itself, the physical nature of the body is not amenable usually for only X-ray based analysis. So here are like 4 different women with the different varying density of the breast. Mammography is X-ray of the breast. And if you see the right-hand corner, even, big lesions of this nature get missed out because the whole breast appears white in an X-ray because it's a dense tissue. And we are trying to use differential density as a means of diagnosis. And that doesn't work in dense breast women. And this happened to be all women under 45 years of age and almost 50% of the ladies above 45 who have dense breasts. And so we go for different other types of modalities. The reason I put this up is to show that, AI can go as far as the modality is able to pull out the information. So you need other modalities. So what we started doing at NIRAMAI is to look at other modalities. A modality called thermography, which was age old, like earlier, with low resolution thermal imaging, people had tried to use this to say whether there is an abnormality or not by using thermal differences, not density differences like X-rays and mammography, more like thermal differences. Using a thermal camera, which many of us are very much aware of during COVID, it's being used in almost every building. Using such a high resolution thermal camera, trying to figure out the temperature variations on the breast or the chest area, and then analyzing using visual analysis, which we call manual thermography, has been around for some time. Now, as you all can imagine, if you are looking at 400,000 temperature points in the form of a heat map, which is a thermal image is actually a heat map, where every color point is a different temperature representation. Like white could be 37 degrees Celsius, red could be 36 degrees Celsius, and so on. It's a general heat map that we use for analyzing data in multiple domains. And so this results in a lot of interpretation errors if it's a manual analysis, more so because there's a limitation of how the visual capability of a person can differentiate between a light yellow and dark yellow, boundaries of the yellow, and so on and so forth, right? So there's several issues that a color-based interpretation allows. So that was the starting point. There is a gap, there is an opportunity because it is completely non-invasive. Nobody is like poking into it. There's no compression, there's no radiation, but there is an accuracy issue. So we started off with this, and then we came up with this method called Thermalytics, thermal analytics. Using AI or analytics on this is what is the newer kind of invention, if you will, that we have done at NIRAMAI, which is one of the flagship products that we have started really making a difference on the ground. So what this does is, if there is an abnormal tissue, there is an abnormal cancer cell, it multiplies at much irregular, advanced, accelerated rate compared to the rest of the body or rest of the tissues, and that results in increase in temperature, increase in blood flow to the area, and that is something that we've tuned our algorithms to detect accurately and say which area is likely to be abnormal. What is the likelihood that it's actually cancer? With the probability of malignancy, essentially, and also identifying the location very as accurately as possible, so that a further diagnosis is just limited to that area. And let's say of FNAC or a biopsy can be done. Furthermore, like maybe an ultrasound scan can be done to understand more about the the structure of the tissue and so on and so forth. It's also important not to look for density differences alone for cancer, because lumps, may be indicative or maybe indicative of suspicious regions, but not all lumps are cancer. Not just for breast cancer, it's across the body, right? Just because there is a lump, it's not cancer. Almost 60% of these are benign, and not all cancers appear first as lump. So basically, you need other methodologies. As I mentioned, a thermal abnormality or a cellular activity abnormality is what we are trying to look at. So just in a nutshell, what we actually made out of this algorithms, that's a long story. To actually take an algorithm that works in the lab to make it really work on the ground, that's a long story, and I'll be happy to sort of, expand on it if that's of interest to the audience. With this, we've been able to clinically prove that we're able to detect much before a lump is felt, that is, before symptoms appear. And we know that asymptomatic detection is early detection to start with, and it enables the early, basically, in treatment, or rather, starting of the treatment and better treatment efficacy and lower treatment costs, and so on and so forth. And we also made it privacy aware because women really hesitate to obviously disrobe in front of even a technician, be it a female technician. So we made it completely non-contact, non-invasive. Nobody sees the person or touches the person during this test, and just measures temperature, so there's no radiation. It works on women under 45 as well as women above 45. In fact, it works on men too, because men also can get breast cancer and it's not known. It's usually detected when it actually spreads to the lungs or brain. It is much, much more affordable. I would say right now we've reached almost 1/80th or maybe 100th the cost of what it is to screen with the current methodology. Just had a wonderful conversation with a huge medical devices expert yesterday in Andhra Pradesh, and it's really possible to bring this test, including all, less than 100 rupees, which is amazing because we are looking at 3,500 rupees plus ops costs and so on, done only in the hospital today as an alternative that exists. It's a very portable device. It's just the size of a water bottle, and it can be done inside a hospital or outside. So basically, it's about automatic generation of quantitative reports from thermal imaging, which is the key place where we use AI ML. And providing these quantitative scores enables the radiologist to quickly say whether there could be an abnormality. And if the scores are high, then he or she can actually spend a few more minutes analyzing. If it's proven to have high sensitivity and the scores are low, with a cursory look, this can be passed. In fact, in villages, when we do a triaging to figure out whether a person needs to be brought to a hospital or not, it can be completely automated because it's provisional reporting that gives. As I mentioned, we can also mark the area of malignancy. So far, we've done more than 100 plus, deployments in hospitals, real hospitals, in Apollo clinics, HCGs, and so on, and thousands of outreach camps in rural areas as well. As I mentioned before, the core innovation in the machine learning. I will spend more time on this itself, just to make sure, we are able to relate to the audience we have here. Machine learning is a part of this whole end-to-end solution, or a end-to-end solution, or the test, in many ways, not just the final classification of saying whether there is cancer or likely cancer or not, which is, of course, the most important aspect of it because the accuracy of this is very important. But what we realized over time is taking images and then building models. Let's say you have, just go to the web, go to a public repository, and maybe like Kaggle kind of store, and then pull it up, and then you develop an algorithm and get, let's say, 90% sensitivity. It's good, but it's not good enough. You get 100% sensitivity, 90% specificity. It's very good, but it's not good enough. Why? Because when the data goes onto the Kaggle store or any other these open public store, before that, there is a lot of work that has gone in to clean up and to make it machine learning ready, training ready, right? So that is something that we realized on the ground. In fact, we realized that when we started off with this thermal imaging as a base, there is almost no one in India who was using thermal imaging. There's only one doctor who had like 200 images, Dr. Ramprakash sir. So with that, and also with a very low resolution. So with that, we actually had to go on the ground, put up the device, and of course, go through the formal ethics committee approval so that we can put up the device in a big hospital and make every person who was going through other modalities, other standard modalities, to come in and take our test and then move on. Then we used this data to actually build up. And then once we had a early version of this algorithm, we actually also put in a test round, right, where the decisions were not made by the radiologist just based on our test. They were actually using several other tests as well to make the final decision for the lady. But at the background, there was a blinded comparator that was going and comparing what we got as a result with alternate modalities. Then we went further on and then said, why only us? Can real health workers in villages do this? So when we started doing that, we realized that people can make so many mistakes on the ground. You can't just give a device to a health worker and expect the whole thing to work, even though you're getting 100% accuracy, let's say, just for the sake of argument. So we spent considerable amount of energy, time, and research actually in trying to make sure that the device is as self-contended as possible. To the extent that if a lady actually uploads an image of lower quality, we say whether there is a problem in the way that she has captured the image, and then give the guidance immediately so she can do a retake and ensure the reliability of the images before even it comes onto our cloud for the analysis. And also, unlike many of, again, the data sets that's available on the web, you are not going to get a nicely segmented area of the whatever disease you're analyzing. You really have to develop accurate segmentation algorithms to figure out where is the area that requires attention, where that requires analysis. And that's also a very interesting problem statement. We had to do a segmentation of the breast area, segmentation of the lesion, segmentation of even the vascularity around it. And then every body is different. Every person is very different. Although we say 98.7, sorry, is the abnormal temperature of the body, it's not really true, right? There's so much variation in it. So a cancer cell can have a much higher temperature in one person and much lower temperature in another. What is the way of differentiating hot areas or high thermal activity versus other? So there's again a bunch of algorithms that we had to develop here, and all of this resulted in multiple patterns also. Initially, we had to do feature extraction manually, as in like we had, of course, there were statistical features. We also had to craft the features in order to build traditional machine learning models like a random forest or an SVM or regression kind of based algorithms. And then once we had sufficient amount of data, then we actually replaced many of these feature extractions, or we added additional features learned from deep nets. So all of this sort of been a big journey and learning. And then finally, last but not the least, how do we integrate this into an existing framework in a radiology department, radiology kind of hospital? There's something called a PACS, picture archiving system. How does it actually go and sit there? So when a radiologist is actually looking at a patient's data, he or she is getting it all in one. So if it's only thermalytics that is being done, the results, the scores that are generated, which I showed briefly before, is sufficient. So many people actually undergo multiple tests. So how do we actually use multiple modalities for doing it? So there's several amount of research that came out as offshoots of this, and it's been an interesting journey. And again, a portfolio of breast imaging and breast health tests that we have done. In fact, it's not limited to breast health. Whatever we have done is applicable to many other type of cancers, and we are already into many of those newer cancers as we speak. And happy to partner with any of you who are interested in working on any of these in the form of internships or whatever opportunities and so on. Okay, so a very quick look at just a very quick dip into the deep learning aspects of this. So one of the things that the technicians used to make a lot of error is to figure out which is the left and the right, because you're seeing a mirror reflection when you actually take an image. And several such things, the angles were not correct and so on, because we were supposed to, and we decided to take, 5 views of the person. And so we used initially to figure out do the tagging properly. We used traditional image processing algorithms, to actually detect, with the help of contours and all. We got about 75 to 80% accuracy. And then once we had sufficient amount of data, we actually built in ResNet with some skip connections as usual, less than 50, and then made a 5-class classification. With sufficient tuning of the loss function, we were able to get a very robust 95% accurate, way of determining the angle, the label itself, the view, if you will. And so we actually make the corrections automatically. Of course, we allow the technicians to say yes, no, if there's a special case, but otherwise we actually don't even ask her to, say which image it is. And this is a big deal when we actually are going into a rural area, because all she needs to do is to just make the person do a video or just take 5 images at whatever location she feels like, and we pick the right ones. Also, once we have the image, the segmentation of the area also was like very important to get it right, because you unnecessarily analyze the neck and the underarms, where there's usually hot temperature tissues that are existing, high thermal tissues. And so there, initially we got about 70% dye similarity with when you actually compare with manual segmentation, when you use contours. And the difference between a thermal segmentation and, let's say, a simple video, right, regular RGB kind of video segmentation, is that we are not seeing any contours and so on, and we're not allowed to take any visual image of this part, as you can imagine. And so it gets a little complicated because it's soft tissue. Anyway, so with that, later again, deep learning, when we used, yes, deep learning really works. We did get really good accuracy. And here, as many of you know, right, in deep learning, what's also important is how we actually augment the data with, of course, scaling, rotation, and all of that, regular ones. But in addition, what we did was we did a flip augmentation and then double the data set, right? Because we did the segmentation and the view labeling, we figured out which side it is, and we made everything left-sided. The cancer is always on the left side, right? And then, of course, we know which operation we've done, and we do the reverse. Right, so that's sort of the thing. And then obviously for segmentation, we use a decode encode architecture. In this case, we use a VNet for doing it. But the pipelining of different type of problems and solutions or networks that we've used to provide the solutions was also a very interesting, multi-phase deep learning network that we had to use internally. This is all in the first box of saying whether the person is doing the right thing in the image or not. And these are some of the images of, the yellow ones are contour based, and then the green and the blue ones you're seeing are all deep learning based. So it's actually much more accurate and precise segmentation boundaries, as you can see. And then we got a dye similarity of 0.92 with this. And what's interesting is when you actually made the same segmentation done with manual, like 3-4 experts, it was 0.92 dye similarity among human experts as well. So it was the best ever, result we've got. We all know how the machine learning for the final stage, I'm just skipping all the middle box and going to the last stage of saying whether there's cancer or not. And we know that any supervised learning has this supervision of training and testing. And here, again, we use some innovative methods, I would say. That is, some of you would have worked on medical imaging classification algorithms, right? So there, what we do is, let's say you're classifying mammography images, or let's say lung cancer. It's an easier one. Now we have chest X-rays, and Professor Chiranjeev did talk about our joint work there, right? So let's say you take a bunch of lung chest X-rays, right? The way you get the label, the training label, the ground truth is that you show this image to, let's say, 5 radiologists, or basically odd number of radiologists, and then say, what do you think? Is there a cancer or not? Where is the cancer? We do the tagging and ground truthing by asking multiple experts. And then we do a different type of combination of this expert results. It could be simple, max vote, and so on, to actually determine the final ground truth. But here, in the NIRAMAI Thermalytics case, we were in a completely different place. Where? Because there's nobody who was confidently able to look at a thermal image and say there is cancer or not. There's only one thermographer who was still not using just thermal imaging to say whether there is cancer or not, because, it's very hard to do it with a visual analysis. So what we did was, I almost alluded to before, is to use a completely off-channel, like, biopsy result as the class label for this. And this is also another thing that we learned on the ground, that obvious, when it may seem obvious now that we have the results when we did this, but no other algorithms at that time were actually doing multi-channel, because it's extremely hard. People who have done clinical trials will tell you how difficult it is to make sure that one person goes through all the tests that are needed to even compare and do a formal clinical study that can be published in top journals, right? So we're talking about training set also. That is where the hospitals don't even know whether there is an algorithm that can work, right? So anyway, so with that, we actually made every person go through all the tests, and only people who went through all these tests using the biopsy result is how we tuned our result, our test. So if there was, let's say, mammography saying there is positive, but biopsy was negative, the final ground truth was negative. Again, it may be obvious now, but what it is actually enabling us is that with the thermal image, we have tuned it to say what biopsy says, which means that it became much more accurate than mammography also, which is the current method. So that sort of, this is one of the results that we got and published in ASCO Breakthrough Summit. 769 subjects who systematically went through our test, followed by standard imaging. And yes, so far, touch wood, we have not missed any cancer in screening population. In diagnostic population, when there's already multiple issues, right? You usually have multiple tests to figure out whether there is cancer or not. Even there, we have 92% sensitivity that we got. So anyway, so with this, when you actually compare with mammography, you will see that this 100% is actually 67%. This is the test that is recommended for breast screening today all over the world. And that's what we're talking about. And so sometimes it's sort of, people may say it's hard to believe. So we've done several studies after this. And in almost all of them, we've got very good results, much, much more sensitivity than mammography and similar specificity. Sensitivity is ability to detect cancer, the true positives by the actual positives, whereas specificity is 1 minus number of false positive rate. So we actually want, more, both have to be high, and basically the operating point in the ROC curve should be more close to the top, right? So that's exactly what we are attempting to do here. And in fact, we got the top 50 abstracts award here. And many, many more awards that we have received over time, right? And also we are one of the top startups, only Indian startup in the top 100 AI startups in the world. As you can see here, India is blue because of NIRAMAI. So this was the learning, that we got in NIRAMAI, doing all of these interesting work in thermal imaging and AI for cancer screening. Having said that, we also tried similar things in COVID, and my friend and collaborator, Professor Chiranjeev Bhattacharya, has already shared some of the work that we did in trying to use similar machine learning based analysis to enable early intervention for COVID by using chest X-rays to automatically say whether there is cancer, whether there's COVID or not, and doing it over just WhatsApp-based images. So what this should tell you all is that there's a huge scope and huge opportunity for AI-based analysis to make a difference, particularly in the developing world where there's a huge shortage in radiologists. But also when you have innovative work and you have results such as what I shared earlier about 25% higher accuracy than existing methods, you also get global visibility. Many of those were shared before, like the Dr. Shisha mentioned, like just yesterday we were called out in Consumer Electronics Show in Las Vegas as the winner of the Global Women Health Tech Award. And then this 25 granted patents internationally and so on basically puts this on a global world map. And here is, I'm very proud to be an Indian taking this solution to the world. And yes, we've now approved as regulatorily cleared for Europe, Africa, and almost 90% through for the US FDA as well. And we've started pilots in Europe, Africa, beyond 100 plus installations in India. I will stop here and see if you have any questions or comments on the test. or any of the work that we've done so far.
I think I can speak for everyone in the audience to say that we are really proud of you as well, like putting us on the map. And
Thank you.
really for something as important, like there are a number of startups, but to really make a difference in people's lives, this is just unprecedented. I mean,
Thank you so much, Professor.
this is no, I mean, we have to clap, I guess. So, yeah, great.
Thank you.
And we can actually start with audience questions. I'm very sure there will be a lot of questions, and I don't want to cut away from that time.
I myself want to start with a question.
Yeah, go ahead.
This is really fascinating. Thanks, Dr. Geetha, for taking us through all your great work. I just see the very word non-invasive in medical technology is very, very relevant. And you took us through one particular example of breast cancer. I just want to know, are there other possible health conditions that could be treated using AI ML, but again specifically focusing on the non-invasive technique? Are you people going beyond this breast cancer kind of things and you're looking for other solutions? So one thing you told about COVID that was related to X-ray, but what other technology you are planning to leverage for this non-invasive methodologies?
Right. So absolutely, you're right. No, this can be used beyond breast cancer for other type of abnormalities or abnormalities in other parts of the body as well. We've started on head and neck cancer. We've in the last 2 years we've also worked on skin-based issues. Particularly, we received funding from Bill Melinda Gates Foundation for detecting, non-invasively detecting abnormalities in the skin nodules called onchocerciasis. This is a disease which is called liver blindness in common terms, which results in blindness and death, and it's about almost affecting 50 million people in the African area, right? So what happens is in this, people develop some kind of nodules like bumps, to put it mildly. And the only way to figure out if there are parasites under those bumps today in for onchocerciasis is to scrape the nodule and put it in the microscope. And they've tried ultrasound and so on, but it has not been effective. So what we have done in the last 2 years, and it's a successful project, and they've come back and said, "You please put up a second project because we really want to take this full forward," right? So, and again, only Indian in this whole area of working in onchocerciasis, selected by Bill Melinda Gates Foundation. So, so we've looked at vascularity around the area, right, using thermal imaging, and we've come up with a protocol for it because nobody else has tried thermal imaging. So we had to figure out what's the protocol for imaging. For example, we actually apply alcohol, clean it up, and then blow cool air for 5 minutes, and then so you have to do all of those kind of even on the ground experiments to ensure that your image quality is good, right? So that is one. And then I know that there are several people who are trying to use microwave and other technologies that you're using. But what, as a startup and or any innovator, focus really helps. We don't want to boil the ocean. There's several people who are trying. Let them try, right? Because it's good for the world, right? If you're specializing in one area, go all out. I don't want to be distracted. I mean, there may be other methods, but we're the only ones who have 45,000 into 6 or 10, whatever, right? 150,000 images of thermal images, and then say whether that is positive or not, right? In this whole world, right? And so that the data knowledge and reading, working on this for 6 years, we as a team want to go forward in this and take it to the farthest possible with this non-invasive methodology. And then also be amenable to multimodal analysis, right? Coming in, somebody else may be working on microwave. I really make an open call. If you're working on any other non-invasive tech, I don't treat us as competition at all. There's no competition here. It's really about, doing good to the human being by taking all the information that is out there that can help them, right? So, we can look at multimodal and so on. For example, we've started one collaboration with one of the IIT institutions in North India, want to use other type of imaging. We said, yeah, fine, we can come together and do it. So that's what it is. We will focus on thermal imaging alone for some more time. And we know how to do in X-rays. We approved it in, X-ray Setu. We've done a lot of analysis on mammography as well to make sure that we know what we are not missing out. And we have multimodal with mammo and thermal, all those things. But we will continue with thermal for quite some time till we assure that we have explored the area quite well for the world. Yeah.
Thanks a lot. Anything from the audience here? Okay, yeah, Shirisha, you want to check if there is some questions online?
Yeah, I have a long list of questions. So
Sure.
one of the very interesting things here is that, first of all, you went away from traditional mammography, where you were using differential densities. And then the second is that you went to the actual biopsy results. So how long did it take you to actually build that data set?
Right. It's an excellent question. I can tell you, September 2007. Like we actually had many, but if you look at the actual, the trial kind of data, September 2017 is when we started the study for just symptomatic women, because you saw, right, symptomatic, there was little less accuracy. So we said, okay, can you do that? And the study ended June 2019. So 1.5 years. You didn't ask me
Yeah.
what's the data size. Data size is just 258 patients. It's
No,
very
I
it's very
totally relate to
now
that.
now it's very easy because now we have built it, right? And we've said, hey, we have done 45,000. Here are the use cases. Here are the women who could not find it in mammo, and here it is. Here is a mammo image. Here is and how, and then everyone wants it, right? Lots of people trying to say, yes, I want to install. And Apollo Clinics itself, we've installed more than 40 places, if I'm not wrong. Yeah. In shared and shared mode. So the initial part is actually very hard, but you have to stay put, right? I mean, that's the one which can give you the maximum benefit later. Because if people had stayed on, maybe people had that patience, this would have happened earlier. It just did not happen earlier, right? And that's kind of our advantage, I guess, if you think of it that way.
Yeah, I mean, I have worked on like burn wound care, and I know how long it takes to like build that data set. So,
Yes. Nice.
and once someone builds that data set specifically for startup, it is also very unusual for you to like being able to collaborate with others. Like, I guess that is the main asset that you have. So, are there what kind? I mean, you are special in this particular area, but what kind of philosophy does drives you to do this kind of collaborative work?
Yeah, I guess it's a loaded question. So, one is passion to solve the problem itself, right? And then basically in my case, I have seen two of my very close friends and cousin sisters die due to breast cancer. And it's been very hard because the existing test did not help them at all, right? And I have seen this. So I firmly believe the world needs another test, otherwise we keep losing 700,000 people every year for this
Yeah.
easily curable disease. And that's huge for me, right? So that's sort of one thing. And then when I say me, right, it's actually the whole team. Right? We keep discussing about this. All of us now understand that's really something that we need to do, that needs to be done. And every time we see wonderful results coming out of a clinical study, blinded clinical study, we went to, I'll give you a Turkey, right? It's some place, you think of it, right?
Yeah.
The doctor said, I think it was Greece or whatever, one of these places. The doctor said, I have two tough cases. You have to do it now and show me. And just like in half an hour, 2 hours, he sent the two tough cases where mammography was not able to determine. And we gave the answer. He said, wait till tomorrow, I'll check the biopsy. And he came back and said, both were right. I mean, every time we have these sort of, validation on the brain, we feel so thrilled about it. And that takes us along. We are in the right path. That's kind of for the validation, we are not doing something wrong to the women. And that's very important, right? So that is another angle. And in terms of collaboration itself, if you again look at how many was that? Like 200 million women who can be impacted. right? Who can
Yeah.
benefit from here? We are just now 50 plus people, right? And in terms of together, we're actually almost 70 now, right? You can't say I will do everything. I mean, you can do everything. You can still be in the
Yeah.
forefront, right? So if you just sort of open your hands and say, whoever wants to do, come together, collaboration, then we can address larger population. We can impact more people. So coming in from, I want to make a difference in the world, and together we win rather than
Yeah.
compete. I think it's very, very important. I know collaborations are, research papers are important. We have multiple papers. You can have, instead of 2 authors, you can have 10 authors. What's wrong? It's okay.
Yeah.
Yeah.
Yeah, I mean, most of the big things which are coming out of even like CERN and like is also like there are multi authors and
Yes,
also climate change,
that actually makes
right?
it
That is
ability to make a
scale.
bigger
Yeah.
impact.
And slightly on the other aspect, you mentioned that some difficulties that you faced when the healthcare workers in the field were trying to image. So, is it a possibility because thermal cameras are now can be used in like your phones as well? Is it possible that this technology can be made into at-home tests? Because like the current at-home tests don't feel scientific
Exists.
at all. Yeah.
Absolutely. So again, I'm very glad to let you know that I mentioned about a meeting that we had yesterday. Yes, we have demonstrated a very, very effective test, which is using a mobile phone and a mobile
Wow.
IR phone. That also, we got the first one working in 2018, end December. But it took us 2 years to make it rugged enough to be used by a health worker there, because we used to put this
Yeah.
plug in, from the USB, and you hold it like that, it falls away. Like, these things are not meant for use in medical device, kind of what you call medical grade, right? So in order to make that happen, you need to do a lot of software fixes, a lot of sort of,
Absolutely.
design fixes, and so on. Multiple things we've learned there, and then doing a study locally, giving it to health workers, going with to medical colleges to try it out before we actually fix the design issue, visibility issues. All that has been done. This device is called My3. This
Oh.
first time I'm speaking about it in a public forum. So this is a device. Thanks for the leading question. So that's a small box. It's less than 1 foot by 1 foot. It's kept on a tripod, and you can connect to that box through a wireless nature from a phone, another phone. And because we always want privacy awareness,
Yeah.
like we have a screen. But for self-use, of course, you don't need both the phones. You can just work with the device. And yes, we are getting it ready for self-use also. But I think we may have to do some more usability fix and add more machine learning models
Yeah.
and so on to make it really dumbify the device for self-use, literally. One is
Yeah. 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 For sure.
duplication, other is also making sure it's and not, some people may do it purposely, and we are talking about, misuse it purposely and trying to sort of, con it, and we don't want to do any of those. More importantly, because it's about a decision of cancer or not, we have to be very careful
Yeah.
about what's the end result. So we are fine tuning it to for self-use with the additional testing and so on.
Great. It is great to hear that we are the first to get this wonderful news.
Yes.
Yeah,
Over to
Srish,
Manjesh.
yeah.
Yeah.
I mean,
Yeah.
as you see, like more we talk, like more news and more information we'll get
Yeah.
from
I'm
Geetha.
just taking
I
over all
mean,
the
I
time.
think
Yeah.
like it's really great pleasure talking to you, Dr. Geetha, and I mean, I think I hope like people listening to you will take this inspiration and do more work like the way you're doing for the social good. So good. Like I mean, of course, I myself have few more questions, but in the interest of the time, we
Yeah.
have to continue. Thanks a lot. Thanks again.
Thank you very much.
Yeah.
All the
Yeah.
Yeah.
best.
Thanks a
Bye.
lot. Yeah.
Thank you. Thank you. Bye.
Okay. Now we have to move to the contributed talks, right? Like now. Uh, okay. So, I think now Shirisha has to take off. I think she's in totally another time zone, right? Like I don't
Yeah.
know what
It's
time it is.
2
It's
a.m. It's
yeah,
2 a.m.
2 a.m.
right now.
So thanks Shirisha for
Oh, yeah. Thank
sharing
you.
this
Thank you.
initial session. It's great. So maybe
Yeah.
then we will continue with the rest of the section. With,
And I would like to
topics.
also say that our next invited talk, which is
Yeah.
at 2 p.m. IST, is also on, perhaps would be on healthcare. I think that's what Charles will be talking about. So we are really getting a lot of information on that one. Thanks, everyone. Yeah.
Thank you, everyone. Bye.